Good morning. Thank you for joining us during Heart Failure Awareness Week, and welcome to today's webinar, Palliative Care Considerations in Heart Failure Management. My name is Natalie Navarre. I am the Senior Program Development Manager for Get With the Guidelines Heart Failure. Get With the Guidelines Heart Failure is a quality improvement program dedicated to ensuring adherence to the most recent evidence-based care guidelines. To learn more about our Get With the Guidelines programs, including Get With the Guidelines Heart Failure, please visit heart.org. Before we get started, I'd like to go over a few housekeeping items so you know how to participate in today's event. This webinar is being recorded. We will send it out via email within 2 hours after the presentation. There are no CEs associated with this webinar, but you can access a certificate of completion in your follow-up email after the conclusion of today's event. You do have the opportunity to submit questions by typing them into the questions pane of the control panel on the right of your screen. You can send in questions at any time during the presentation. I will collect these and will address them as time allows during the Q&A session at the end of today's presentation. If you experience any technical issues during the presentation, first try refreshing your browser. If this does not work, please refer to the GoToWebinar customer service team, whose contact information is in your webinar confirmation email. To view live closed captioning for this webinar, please utilize the hyperlink in the chat. Our presenter today is Dr. Larry Allen. Dr. Allen is the Chief of Cardiology at the University of Colorado, Chair for the Clinical Cardiology Council of the American Heart Association from 2023 to 2025. He is on the writing group for the 2022 AHA-ACC Heart Failure Guidelines, and he is a member of the AHA's Heart Failure Systems of Care Advisory Group, which oversees the Get With the Guidelines program. Dr. Allen's clinical research interests include improving equitable delivery of evidence-based heart failure treatments, anticipating progression into stage D heart failure, and helping end-stage patients make tough decisions regarding invasive therapies and palliative options. Meanwhile, Dr. Allen keeps himself clinically grounded by regularly seeing patients with heart failure, LVADs, and transplants, and he is consistently voted as one of Denver's top doctors in 5280 magazine. Dr. Allen, feel free to take it away. Thank you.
Well, thank you for having me today. It is a real honor anytime I get a chance to speak on behalf of the American Heart Association or with the American Heart Association. It's also an honor to do this event during Heart Month, and I hope all of you had a great Valentine's Day last night. So these are my disclosures. I think the most important disclosure is that I really am an advanced heart failure and transplant cardiologist who thinks a lot about the care of patients with heart failure. I do see patients and I work on operations. I also work with the American Heart Association on quality improvement programs. But I'm not a palliative care specialist. And I think the care of heart failure patients is really a team-based sport between patients, their families, cardiologists, nurses, other specialists, including the palliative care community. So I'll give you my perspective today, but I want to recognize that this really is a multidisciplinary space, and we can only do it well if we work together. The American Heart Association works hard to create stronger systems of care for heart failure patients, and it asks, how do we improve guideline-directed medical care every step of the way? And this obviously starts with prevention of cardiovascular and brain disease, and then looking for early detection signs and warning signs of developing disease, including heart failure. But unfortunately, most of us actually start interfacing with heart failure patients when they initially present with worsening heart failure to the hospital. 70% of the resources allocated to the care of patients with heart failure occurs during exacerbations when patients decompensate and end up in the hospital. And so much of the work around improving the care of these patients actually starts during that hospitalization, and consequently the Get With the Guidelines program is fundamentally focused on initially that care that patients get in the hospital, and then hoping to improve care by the time of discharge, and then encourage that to continue on in transitional care. Once patients are discharged from the hospital, they can have different courses, obviously. This is to return home. The average patient who's hospitalized with heart failure is in their late 70s. So some of these patients will go to skilled nursing facilities and rehabilitation to try and improve. And we also work with those types of facilities. But unfortunately, heart failure is a progressive disease in many patients. And although we can often stabilize the disease, sometimes cure it, at times it does get worse, causing severe symptoms that cannot be alleviated, and ultimately sometimes progressing to death. And so today what we'd like to focus on is those patients who are in particular need of palliative care approaches, and sometimes consideration for enrollment in hospice. So in order to talk about palliative care and hospice, I thought I would do a few things in the next 40 minutes or so. One is to talk about why are we talking about palliative care and heart failure, and what makes palliative care so important in this disease. And that includes a high symptom burden, prognostic uncertainty, and often very complicated decision making. Then we'll talk about exactly what do we mean when we say palliative care. What are the different aspects of palliative care with a division of primary or basic palliative care, and then focusing on specialty or secondary palliative care, and then also talk about the hospice benefit. I'll spend a little time talking about specific palliative care interventions, which include symptom control and relief of suffering, but also include advanced directives, decision-making, and other aspects of care, including bereavement. And then we'll focus on the guidelines from the AHA and what they recommend, and then finally talk about how do you actually do this in practice and provide palliative care and hospice to your patients. So why palliative care and heart failure? Well, heart failure is associated with significant mortality, high symptom burden, poor functional status and quality of life, frequent hospitalizations, and a mortality in our patients that is relatively high. We often quote a 50% median survival or 50% mortality at 5 years, although this is highly dependent on the situation and the patients. So a younger patient who's stable in the ambulatory setting, who's not been hospitalized, actually has a survival that's decades long on average, whereas older patients who were just hospitalized have a more 50% mortality rate that is often less than 3 years. While guideline-directed heart failure therapies can improve survival, reduce congestion-related symptoms like shortness of breath and swelling, improve quality of life, people living with heart failure continue to have unmet care needs and face uncertainty about their prognosis, and palliative care can help with this. So, people are often scared of cancer, and especially metastatic cancer. And this was a study done by my good friend David Beckelman some years ago. He does palliative care and psychiatry, both in the cancer space and the heart failure space. And what he showed in his work is that patients with advanced cancer, compared to patients who had symptomatic heart failure, actually had about the same number of symptoms, a lower depression score, and a higher spiritual well-being score. So, the patients with heart failure really are affected by not just a high mortality like cancer, but also a very significant symptom-based and emotional-based symptoms. The other thing that is challenging about heart failure is that the clinical course of heart failure is relatively unpredictable. So this is a schema that I find to be really helpful. In some patients, maybe who have arrhythmic issues, you can look at the light blue line, where patients feel fine, they do well, and then all of a sudden they drop dead from arrhythmic death. That would be similar if you were in a car crash. So that's one way that people die. Another way is that people get cancer, where they start out, they find out they have a lump, they get a diagnosis of cancer, that cancer is initially treated, but then it sometimes breaks through therapy if it's metastatic. And then there's often a relatively rapid decline, which you can see in the dark bluish purple line. And then we have older patients, those with frailty, dementia, Alzheimer's disease, where for many years they can go on kind of with a lower level of functionality and ultimately death, but this can be prolonged. But diseases like heart failure, other diseases, it would include COPD that has exacerbations. And I would actually argue now cancer, where there are an increasing number of therapies that sometimes rescue patients temporarily until the drug doesn't work again, and then new drugs are tried. Those patients have an undulating course where they get sick, they decline, they're put on medical therapy, they get diuresed, they feel better for a while, and this lasts for an indeterminate amount of time, and then that may be stable and then worsen again and have another hospitalization. Not only is that undulation hard in the sense that people, feel okay, then they feel bad, then they feel okay, then they feel bad, but it's unclear when somebody feels bad and ends up in the hospital, is that the last time that, and they're not going to get better and they're going to die, or are they going to improve and maybe have months or years of good life left? And this is often, we struggle with this in the hospital or even in my clinics where I see patients who are quite sick and I really do not know what the future holds for them, even after seeing patients like this for years. This can even happen after we treat patients. So they start out with an undulating course. We think they're getting worse. We do something drastic to try and treat them, like place a left ventricular assist device. And even after a left ventricular assist device, patients can have varying courses. So they may die in operation or soon after in the red line. They may actually feel much better in the green line and then have a catastrophic stroke and die suddenly. Or they may actually have ongoing heart failure. About 15 to 20% of patients with an LVAD continue to have right ventricular dysfunction or inadequate LVAD function and have an ongoing blue undulating course. And then some people do better and then may die of other diseases or just gradually decline. So it is this prognostic uncertainty that I think really makes it hard to counsel patients about when to be aggressive about therapy and maybe when to change their approach and be less aggressive to care. So I'm guilty of using data and my statistical skills to create risk scores, but there are literally hundreds and hundreds of risk scores about the prognosis of patients in heart failure and when they either are likely to die or have hospitalization or other events. So with all of this data and all the hard work that's gone into producing risk scores, one of the things I think that we're tempted to do is say, well, let's apply risk scores in the clinical care of our patients, maybe put them into the electronic health record or calculate them ourselves on online tools. And the risk score will tell us whether our patient is going to die soon and should really get referred to palliative care or hospice, or whether this patient's actually going to get better from their hospitalization and go forward. So that seems like that should be relatively easy. But to illustrate this, we did this study, and this is actually one of my favorite analyses that I was a part of. We actually went to Kaiser, and we took 10,000 patients who had heart failure. And at a point in time when they had heart failure, we said, okay, let's calculate the risk score for these patients. And then what we'll do is then we'll follow those patients forward for a year, and we'll see what actually happens to the patients. And what did happen is that of the 10,000 patients, 8,400 of them, or 84%, were alive at 1 year. And then on the bottom, the x-axis here, you can see we use the Seattle Heart Failure Risk Model, which is a commonly used risk model, which is very well validated, and looked at what the 1 year estimate of risk is. And that risk was anywhere from 0%, although nobody was at 0. There's a few people at 2 or 3%. And then most of the people were lumped kind of in the 10% range, or 0.1. And then you can see there were a few people, very few out of 8,400, who in the red area had a risk of death that was calculated to be over 50%, which are the people I would think about, well, gosh, I should start thinking about whether they need, palliative care referral or hospice. So this model looks like it works pretty well. Most of the patients who lived are way over on the left on the risk score, and very few patients who lived looked like they were maybe going to die on the far right. Here's the problem, is that 1,600 patients, or 16%, 1 in 7 died. And these are the risk scores for the patients who died, which is that if you look, the average risk prediction is 11% for people who are alive and kind of around 17% for people who died. So the risk is higher or worse in the patients who actually died. But the problem is that the vast majority of patients are still way over on the left, and you would say, oh, well, they have a 17% chance of death. Most likely they're going to live, and it turns out that they died. The other thing is that the way that I would like to use this risk model is to say, well, who's going to die in the next year? Who has a risk that's really in this greater than 50% of dying? And the answer is, yeah, there were a few people that did die that had this risk score, but there were just as many people who were alive. And so the risk scores are not particularly helpful at telling us exactly what to do. They can help us target higher, medium, lower risk populations to try and be more efficient with the treatment that we provide and the referrals that we give. But the risk scores don't actually tell us exactly what to do for the patient sitting in front of us. And so I like this quote. It says, attempts to determine through data collection which patients have a low or zero chance of survival, and conversely, a zero chance of death, have been largely unsuccessful. The other thing is that our patients are somewhat confused. This is another study I participated in many years ago, but I think has been replicated by others more recently. So if you have heart failure, that's a pretty bad prognosis. And on average, reduces people's life expectancy quite significantly. However, when we went to a clinic and asked about 150 patients, what do you think will be the eventual outcome of your heart failure? And all of these patients were in chronic heart failure, and I think theoretically that would not be cured from their heart failure. Almost 10% thought that they would be cured and do fine, and another half the patients thought that they would have a normal life expectancy because they'd been diagnosed and were being treated for their disease. And that's just not true. And so I think not only is heart failure unpredictable, but patients, I think in reaction to this, either have hope or unrealistic expectations. And that can sometimes create confusion when you're trying to make good decisions about how to treat the patient, how to help them anticipate worsening disease, and sometimes how to have a graceful death. The other thing is that we often talk about death, and obviously to the majority of patients, staying alive is really their top priority, but that's usually balanced with other priorities. So while they may want to survive, quality of life and what that survival looks like is very important in terms of symptoms, physical function, their mental and emotional status, and even their social interactions and support. And then patients individually, their families, and even society care about the costs and burdens of providing care. And this includes not just out-of-pocket costs, but what are the indirect costs that are related to going to appointments and missing work and asking your family members to take you places? What are the lost opportunities? What are the caregiver burdens? What's the loss of independence? And trying to put that all together, that one, it's very, very difficult to do that in a risk score. But the other is that's hard to do even just through kind of data collection. This really involves complex conversations with patients and getting to know them. This is a pretty complicated figure, but I want to talk through it because I do think that there are generally kind of two rough groups of people and how they approach the end of life. I have one of our colleagues here at Colorado, Laura Scher, has put this in a scale, and she calls it the medical maximizer and medical minimizer scale. Medical maximizers, I think of the word as aggressive. These are people who want to, quote, do everything. And those patients will say, I just want to live as long as possible, no matter what. And they're willing to take risks, do big surgeries, be in the hospital to do that. And their clinical course here if you take the x-axis as time and progression of disease, and the y-axis as on top, one is be super aggressive, and on the bottom, you know, I'm going to kind of go to comfort measures only. These patients, you know, they say they want everything, but when they come in and say they want cancer screening and they're dying of heart failure, we say, well, that's not appropriate anymore. So even though they may want that, we start to cancel those kinds of things. But generally what happens is they don't really want to make major changes in the aggressiveness of their care until the end is immediately in sight. They have a catastrophic stroke, they have sepsis, and you know, they're potentially even getting resuscitated, and the team really says there's nothing we can do. And at that point, you may turn off the ICD and you know, really help the patient die in the immediate sense. And often this happens in the intensive care unit. However, I think there are other patients who are more minimizers, or they are patients for whom the value of survival diminishes as their symptoms worsen and their prognosis becomes worse. And so these patients actually decrement their care, or they become less aggressive as they move forward. And a lot of what I do is help them navigate this course of stopping certain things and changing the approach to care. So we may actually inactivate the shocking functions on the defibrillator quite early in a patient like this, so that should they be at home and start to have ventricular arrhythmias, they don't die getting a lot of shocks. We may find that even though guideline-directed medical therapy is really helpful at stabilizing patients, at some point it may just be worsening their symptoms to the degree at which now it's actually more causing severe symptoms and making people feel worse rather than actually improving heart function and survival. This is usually quite late in disease, but not necessarily once the patient is in the ICU. And then, you know, thinking about when to enter hospice, and ideally that's not one day before death. You know, engaging hospice, getting people home, having them spend time with their families. Hospice is really, I think, designed to do that well when there's a little bit of time, days to weeks to months, for patients to have made that transition and benefit from hospice care. So the other thing is that, you know, cardiovascular disease is the #1 cause of death in the world and the United States. It is the #1 cause of palliative care needs. So most cardiovascular diseases progress to heart failure or chronic angina or other symptoms. And so many people think of palliative care and hospice as really being a treatment mostly for cancer, maybe for people with advanced AIDS, maybe in advanced Alzheimer's. But when you look at the data, and this is from the World Health Organization, cardiovascular disease, not surprisingly, are symptomatic diseases, most common diseases, and palliative care is really applicable to these patients, and they really account for the greatest palliative care need. So we've been talking about palliative care, but I want to give formal definitions here. Palliative care is a team-based, evidence-based, multidisciplinary approach to improve quality of life for people living with serious illness and their families who are living with them. Its goal is to relieve physical, psychological, social, and spiritual suffering and address unmet needs that the regular medical team is either unable to fully address or handle. And as such, palliative care holds the potential to improve quality of life for people living with heart failure by complementing disease-directed therapies. And this is for patients and their loved ones and caregivers. Now, this palliative care in heart failure and other cardiovascular diseases happens within the context of also providing heart failure care. So I think there's a couple of main domains in palliative care. The first is really to relieve suffering, right? So that's to improve symptoms, which in heart failure are often dyspnea, fatigue, edema, pain. And when you think about this, actually palliative care can help do that. Opioids are very effective at relieving dyspnea, but so is furosemide. And so symptom control is often a combination of more palliative approaches, often with ongoing targeted heart failure care approaches that can still achieve palliation and relief of suffering. The second is obviously to focus on the family when the patient is sick and then after their death and bereavement, and to provide wraparound psychological and spiritual support, which can help patients relieve suffering by being able to handle symptoms that can't be alleviated otherwise. And then palliative care has significant, palliative care specialists have significant training in communication. And I think a lot of times when we work with specialty or secondary palliative care, a lot of what they do is really come in as a third party and really make sure that there's good communication going on around progressive disease, end of life, difficult decisions. And so they use formal decision support training. They often talk about preparedness planning for big events that are coming in the future, and then help patients execute advanced care directives so that the patient and the family, I think, are in line with the medical team, both in terms of what's possible, what's expected, and then also what is value concordant with the patient and their desires. So the National Consensus Project Guideline on Palliative Care says the overarching goals of palliative care are that all patients with serious illness, irrespective of their diagnosis or prognosis, should be considered for palliative care. All clinicians involved in palliative care, including primary care providers and specialists, are responsible for considering timely palliative care. And the 8 domains and principles that should be included when designing new palliative care programs or educational curricula for people with serious illnesses, all of those domains should be included. And these are the 8 domains: the structures and processes of care that underlie the delivery, the physical aspects, the psychological and psychiatric aspects of care, social aspects, spiritual and religious existential aspects, cultural aspects, specific care at the very end of life, and then ethical and legal aspects that all come together for patients with life-threatening progressive disease. So most of you are aware of this, but I think it's helpful to go through the difference between hospice and palliative care. On the right, palliative care is an approach to care. Its focus is on pain and symptom management primarily, as well as other domains. The patient actually does not have to be terminal to be getting palliative approaches. And the patient may still be seeking aggressive or even curative treatment, even if palliation and palliative practices are applied. And it's generally not specifically linked to reimbursement. So a palliative care consultation may be called and somebody may bill for that. But many of us are providing palliative care using palliative care principles that are really just part of routine care. Now, hospice is different. Hospice, at least in the United States, is really a specific insurance benefit. Most hospice care is provided by Medicare, given that that covers older patients, and that's where a lot of death occurs. Its focus is also on pain and symptom management, but the patient has to have a terminal or a diagnosis, and you have to have 2 doctors, generally the patient's primary doctor and the hospice doctor, say that based on their knowledge of the patient and the disease process, and maybe some risk models, which I said are not that accurate, that they think the patient has a life expectancy of less than 6 months. And many times patients really have to forego curative treatment because the hospice benefit is often capitated. There's a single payment per day or per month that is applied to the given to the hospice agency to provide often in-home nursing. And if a patient is being continued on very expensive therapies that are designed to cure, that no longer works with the way the hospice benefit is constructed. So the hospice agencies, I think, have some decision-making ability in what can or cannot be continued, but very expensive therapies often, even if the patient would like to continue them, are not necessarily able to be continued. And we've seen that with IV inotropes like an infusion of dobutamine or milrinone, where if patients are enrolled in hospice, about 50% of hospice agencies will consider allowing that to continue, and 50% will say that it needs to be discontinued if they're going to accept the patient. I also want to talk about these, a couple of just conceptual models of the way to think about curative or restorative care, what we're normally doing with our patients versus palliative care. And I think a simple way to think about this is, okay, we're taking care of a patient with heart failure, they're doing okay, and then they get worse, and we don't think they're going to get better, and then we switch them over to a palliative approach. That's the way I think we've historically thought about this on the top. I think probably a better way to think about this is that when people are early in their disease, mostly what we're trying to do is cure them, get them feeling better, their heart working better, and helping them live longer. But as the disease progresses and they become less responsive to care, we tend to de-emphasize the curative care and start to focus more on palliative care as they approach end-stage disease. And you can see that transition kind of occur here. But this is really what I think happens in real life, which is everybody kind of has a different course. Oftentimes early in the disease, patients respond pretty well to therapy. But then eventually it may get worse. They may develop more comorbidities. They may develop further aging and frailty. And then patients may start to have worsening disease that undulates. Each of the asterisks are a hospitalization. And then eventually that last hospitalization is really bad. And the patient says, this is probably too much. And the doctors and nurses are saying, well, yeah, we really have kind of exhausted our options to get you feeling a lot better. And patients then at the end may transition to hospice and really de-emphasize the curative care. And then once patients die, there is actually some consideration of what happens after with the family and bereavement. And I like this figure a lot, which is why we kind of remade this figure here and put it into a scientific statement on medical decision-making in heart failure that, again, talks about the clinical course, what that looks like on the top, and then the types of care that are provided on the bottom, with a real focus that oftentimes patients early in their disease are relatively manageable, but once they start to transition from stable symptomatic stage C heart failure to end stage D heart failure, this is a time where we really need to focus on complex decisions, think about whether there's a change in approach, consider whether patients are even eligible for drastic treatment options like LVAD or transplant, and if not, or if they don't want that, then start to really consider specialty palliative care referral and potentially enrollment in hospice. So along those lines, I want to focus on the difference again between primary and specialist or secondary palliative care. So primary palliative care is what we all do. It's a basic knowledge and skills for all healthcare professionals to think about how do we alleviate suffering, help patients think about control around what end of life and death looks like, think about filling out advanced care directives or living wills, treating basic symptoms, including depression and anxiety and shortness of breath. And then specialist palliative care are clinicians who've actually done a fellowship with specialized training and experience in the care of seriously ill and dying patients. So this is a team approach. It's not that we either do primary palliative care or we do secondary palliative care. Often we're starting with primary palliative care, we're still delivering heart failure, we're still helping with palliative care needs. And then when things get really complicated, we call in formal palliative care specialists to help us out. Again, when I say us, that may be a cardiologist, it may be a cardiac APP, it may even be one of the nurses on the team helping. It may actually be primary care who's managing a patient with HFpEF, where there are multiple comorbidities and they actually feel comfortable doing that. It may be a combination of all the above. Clearly, the patient is in the middle, and they are often bolstered by their family, their friends, and their communities. And then again, not only the community, but other healthcare providers and psychosocial support staff are all important in any complex progressive chronic disease, but especially as it transitions to end stage. Sorry, and then this is how I kind of think of secondary palliative care overlapping with primary care. Again, we talked about the components of palliative care. I just want to again say palliative care involves advanced care directives that help with decision making. It includes pain and symptom management fundamentally. It helps patients think through their values, goals, and preferences so they can state those goals of care. It helps people communicate those, what they want, and what's medically reasonable. And then it also includes hospice care at end of life. For symptom control, there are a lot of things that we can do. I already touched on this before, but heart failure therapy itself is highly focused on symptom control, and diuretics themselves and the control of congestion are very central to helping people feel better. And then in end-stage disease with reduced ejection fraction, there's some decent data that says that in certain patients, when used appropriately, infusions of IV inotropes can help with symptom control and fluid control. Opioids are particularly helpful. I think they not only treat pain, they don't cause kidney dysfunction like NSAIDs do, which is often a problem with cardiorenal syndrome and end-stage disease. And they're very good at relieving dyspnea. I think we all have highly appropriate concerns about opioid use with the just terrible opioid epidemic around fentanyl and heroin and other even prescribed opioids. But there's good data to say that even though that's a major concern in our society, that at least among patients with end-stage heart failure, abuse is limited. So I think we need to navigate this carefully, but it doesn't mean that we should just say we're not going to prescribe opioids because of the challenges and the societal concerns. And then psychological support to bolster all of this is really important. Unfortunately, patients with severe heart failure don't respond particularly well to SSRIs, but they do respond well to counseling and support, and are often helped by spiritual advisors and others concerned about their spiritual well-being. I think sometimes we're concerned about stopping medicines. Older patients who have chronic disease tend to have similar relative risk reductions from guideline-directed medical therapy and hypertension treatment and even some of the diabetes therapies. So we should not stop those diseases just because somebody's older or has significant disease. However, as patients truly transition into end of life, I think at that point, when their goals of care have really changed, some of the therapies that have small benefits that accumulate over years, like statin therapy, it may be reasonable to discontinue those medications. And this is a paper that was done by my colleague and our chief medical officer here, Gene Kuttner, who actually did a randomized controlled trial of statin discontinuation in patients with severe coronary disease who actually had entered end-stage disease and stopped it and really didn't see a difference. So I think a little bit of reassurance there with some data. And then sometimes stopping these things can improve quality of life. Patients get less side effects of the drugs, but they just kind of avoid polypharmacy as they transition what they're doing. Medical decision-making is important. I already mentioned advanced care directives multiple times. More robust than that are the physician orders for life-sustaining treatment. This is one of the forms that's been developed. It goes through A, B, C, D, E, which talks about CPR, medical interventions, stopping things like antibiotics and artificially administered nutrition, and then talking about specifically addressing medical conditions. So I think using forms like this to really give structure and specificity to the discussions that we're having can be helpful and can make it easier to direct future treatment. Shared decision making is really critical in complex disease, and I think given the increasing number of therapies that we have and the increased overall complexity of the care that we're able to provide in patients who increasingly have multiple chronic conditions, it's really has become impossible to just do everything for patients. It's not appropriate even. And so what we need to do is help patients navigate what are the highest value therapies for them, and focus on first doing the highest value therapies, then moving to moderate value therapies, and maybe deferring or even avoiding low value therapies that can be distracted for patients. The way I think about shared decision making is that it is a meeting of two experts. The patient is an expert on their values, their hopes and fears, what their home life looks like, what their family's concerned about. And the clinician is an expert on what options are medically reasonable for this patient based on the medical knowledge of the patient, and then helping advise patients on what are the best, worst, and likely outcomes for the different options that are being offered. And then there's kind of a discussion and deliberation between the provider and the patient with these two separate knowledges to figure out, well, when is the right time to either transition to hospice, or is doing something aggressive like a TAVR or an LVAD appropriate in a patient who has gotten quite sick and has other medical problems. And I think this is tricky in the art, but it's the art of medicine, and it's what makes our care so good. I do really like this best case, worst case scenario. So this is some work that came out of the surgical group in Wisconsin. And the example they often talk about, which is not a heart failure one, but could be thought of similarly, is an older patient has, a ruptured viscus, has peritonitis. And so the question in this older patient is, should the patient go to get a laparotomy and exploration of their belly to try and cure a serious infection? Or should the patient really get supportive care? And what does that look like? And we don't know because it's uncertain. But we can say if surgery happens, well, the best case would be that the patient gets through the surgery, recovers in the hospital, and then gets back to the nursing home. But the patient's probably not going to be better than they were prior to this event. The worst case is that the patient develops complications after surgery, has a terribly aggressive days of pain and suffering in the ICU, unable to talk to family, and then dies. And then what's the most likely? It's usually somewhere in between. And then supportive care is like, well, what if you decide not to go to surgery, and what does palliation look like? And I think sometimes we tell people, oh, if you do palliation, everything will be fine and you'll have no suffering. And that's actually not true. I think palliative care is never perfect, but sometimes it goes relatively well, and even sometimes it doesn't go that well. And I think talking about a little bit of the variation and having honest expectations about what declining surgery and doing supportive care and maybe going to hospice looks like, that's also important, and giving the range of that experience is key. So a little bit of data to finish up on palliative care. One is that advanced care directives, we always talk about advanced care directives. We've used it as quality metrics. What do your patients have an advanced care directive executed and filed in the medical record? I think overall the intent of advanced care directives is great, in the sense that if you sit down and fill out an advanced care directive, you're actually thinking about what is it going to look like when I eventually die, because everybody dies, and am I an aggressive person? Am I a maximizer, or am I that kind of less aggressive minimizer? And do I, want everybody to do everything they think they can until the bitter end? Or am I a person who wants to say, well, put me on a ventilator for a couple of days, but if things aren't looking good, I'd actually think you should take me off relatively early. Those are the kind of discussions that you want people to be having. You want them to think about it. You want them to talk to their family about it. And then you want them to write some of that down. I think what my concern is with advanced care directives is that people change. You're asking patients to anticipate the end of life, and they have no idea what that looks like. We ask people to say, well, what would you do if you ever had a stroke? But they've never had a stroke. And so it's very difficult to ask people in the present to predict what they would want and do in the future. And so that's challenging, and not surprising if you take people who said, I wouldn't want you to, intubate me or do cardioversion and resuscitate me with chest compressions. a few months later, if you put them in the hospital, actually they'll say that they want those things. And I think that's okay. It just recognizes not only the uncertainty of what happens to patients in the course of heart failure, it also just recognizes that things change and people learn and they get different experiences. The other is that, you know, I'm a very transparent doc. I tend to be pretty direct with folks. And I have actually softened that a little bit over the years. I still am pretty direct with people, but I do try and sense a little bit about how much they can accept and take. And I thought this was a pretty powerful study that was done in 2016 where they randomized patients to palliative care led meetings for chronic critical illness in the ICU. And they thought that having these palliative care led meetings would be helpful, you know, help people withdraw care at more appropriate times, help families feel a little better about it. And what they actually found is that forcing people to deal with all this death actually led to what looked like an increase in stress disorder symptoms and anxiety. It doesn't mean that we shouldn't have these discussions. I think it means that we need to be a little bit gentle and not push people to them. We should kind of nudge people to these kinds of discussions. So what do the guidelines recommend? Well, I had the real honor of working with Paul Heidenreich and this amazing team who reviewed the data and used their own experiences and research to define what's optimal care for patients with heart failure. And section 13 in the guidelines talks about palliative and supportive care and shared decision-making and end of life. It gives a class 1 recommendation for all patients with heart failure, palliative and supportive care, including high quality communication, conveyance of prognosis, clarification of goals of care, shared decision-making, symptom management, and caregiver support. The domains of palliative care should be provided to improve quality of life and relief of suffering. And that is primary palliative care. That is what we all should be doing. Another class 1 recommendation is for patients with heart failure being considered for or treated with life-extending therapies, the option for discontinuation should be anticipated and discussed through the continuum of care, including at the time of initiation, with reassessing the changing medical conditions and shifting goals of care. This specifically applies to ICDs, that just because somebody gets an ICD does not mean they need to leave that ICD on, and we should be very careful and purposeful about telling patients that the defibrillator, just because it's implanted, does not need to stay on. It's very appropriate at some point to change and turn that off. We also recommend for patients with heart failure, particularly stage D, who have either inotropes or being evaluated for transplant, or LVAD, who have uncontrolled symptoms, who have multimorbidity, who have cognitive impairment, who just have difficulty at the end of life where it's becoming too much. Palliative care consultation can be useful. That's a 2A recommendation, so consider that strongly. And then for patients with heart failure, executing advanced care directives can be useful, again, 2A. And then in patients with advanced heart failure and expected survival for less than 6 months, timely referral to hospice should be considered, again, a 2A recommendation. And then finally in section 8, earlier on where they talk about stage D or end stage heart failure, a class 1 recommendation is that, again, these are re-emphasized, that timely referral to heart failure specialty care is recommended. You know, the guidelines from the US are quite similar to the ESC guidelines. So I do actually like to compare what the Europeans are doing sometimes to see how their perspective is a little bit different. And I just included what the AHA guidelines said and then what the European guidelines do. Actually, the AHA guidelines are a little more specific, which I think is helpful. And I was able to participate in that in terms of having official recommendations. This is, I think, very tricky, is when do you refer to specialty palliative care? And I just went over on the far left column is the 2022 guidelines about when to refer with certain populations, including patients that can't be controlled, their symptoms can't be controlled with heart failure therapies, patients with really big medical decisions like left ventricular assist device, where it's mandated, and then patients who have other conditions or frailty and cognitive impairment that complicate the decision making. In the middle, there's actually a European Society of Cardiology 2020 paper on when to refer, and they give specific criteria. It may include ICDs when they're giving shocks that may not be appropriate, or when they're having trouble, people are having trouble deciding when to deactivate. They also talk about LVAD when there's a lot of spiritual or existential distress, when patients are having recurrent heart failure admissions and can't control their symptoms, when their functional status really gets bad and they have frailty, when the informal caregivers and surrogates disagree on goals of care, or in certain parts of the country like Colorado, where medical aid in dying is available and there's a request for assisted suicide. I actually really like the I Need Help acronym. It's basically, if a patient has any of these acronyms, basically if the patient is on inotropes, they're saying to you, I'm in serious disease, I have end-stage disease. If I have high BNP or NT-proBNP, or my NYHA class is 4 and I can't get it better, that I need help. So it goes through end organ dysfunction like renal or liver dysfunction, and EF that's less than 20%. Again, shocks, hospitalizations that keep recurring, uncontrolled fluid congestion, low blood pressure, or that you're taking patients off of their beta blockers, sacubitril valsartan, because they just can't tolerate them anymore. And then I actually had the pleasure of participating with Dr. Chang and a group where we actually asked many, many different providers around the country what they think are specific criteria for referring patients to palliative care specialty. And I think this takes this to a higher specificity, a higher level, with a lot of criteria that lots of people vetted. And I think you can use this list potentially within your institution or in your clinic to think about maybe what's a checklist, or what should I really think of as reasons why I ought to call my palliative care specialist or place a referral to specialty palliative care. So I did include this. This is actually the National Coverage Determination for placement of a left ventricular assist device. And this is where policy kind of helps formalize palliative care. And it says that, if you're in an LVAD program like ours, we have an advanced heart failure center that does LVADs and transplants. We're not allowed to get paid for placing an LVAD unless we have a palliative care specialist as part of our team, and they're involved in the care of the patients and the decision-making that happens. And I think this is a great example of how all the things I just talked about are good, and we should think about doing them, but it's nice to have some teeth behind them to make sure that that we're asked to do it, and then that we're getting paid to do it. I do think there's been a real change in the last 20 years. This is some data that we put together. Heider Werrick has been very interested in this space, done incredible work, and has been kind enough to involve me in some of it. But you can see that hospice use actually has come up significantly in recent years, and that the proportion of patients who are dying in hospice has actually increased markedly from 2003 to when this data ended in 2015. Now, at this point in time, about 5% of cardiovascular deaths were in hospice, but that was way up from almost 0% before. And this trend has actually increased and almost accelerated in recent years. We actually use the Get With the Guidelines database to look at the hospital level. So 300 hospitals participating in Get With the Guidelines who gave us data on what % of patients were being discharged to hospice. And what you see is that there's actually a pretty significant variation. So even after you adjust for, on the bottom in the B panel, adjust for severity of disease, use of hospice for heart failure discharges among hospitals varied between less than 2% to greater than 8%. And that is, not huge. A lot of folks in the middle are around 4%, but some significant differences. And then Get with the guidelines heart failure includes palliative care measures now. These have been added, which is to say, was an advanced care plan and a surrogate decision maker documented or discussed during the hospitalization? And was an advanced directive executed and uploaded to the medical record? And so we want to collect this because we think it's so important to the overall care of patients with heart failure. So in summary, you should build and maintain robust systems of palliative care in your system. We want you to think about providing primary palliative care to all of your patients, and that everybody should be doing those basic primary palliative care principles and applying them to practice. And then you should think about when to call for help and get secondary palliative care. And I gave you a list of criteria that can help you decide when to do that. Palliative care needs to happen in the inpatient and outpatient setting. And unfortunately, many places really don't have outpatient palliative care, and we need to improve that in the United States. And the palliative care then links to hospice services, specifically for those who really get into that prognosis where they likely have less than 6 months of life. And then in order to systematically address palliative care needs in patients with heart failure, you should characterize their clinical status. You should estimate their prognosis, understanding that risk models are poor when applied to an individual patient, and that you actually need to tell patients there's a lot of uncertainty, and think about those best case, worst case, most likely scenarios. Solicit the patient's values and beliefs. And for me, it's a lot about not only what are their major life goals, but when we say elicit care preferences, are they an aggressive, do everything person, or are they more of a, I want my independence, I'm less aggressive, I'd rather have more of a peaceful death. Review treatment options that are appropriate, consider those options, conduct preparedness planning, make tough decisions, stay with your patient regardless of what they decide. And then at the end, we can't improve unless we have data. And so we have measured performance. We appreciate your participation and get with the guidelines, and we appreciate your answering the questions about what you're doing around advanced care directives and medical power of attorney. So thank you so much for having me today. And I hope the second half of your Heart Month is terrific. And we'll open this for questions now.
Larry, we are actually out of time. So we have a couple of questions that I will send your way. And if you don't have any closing remarks, then I can close this out.
That's great. And how do people get the slides?
They are in the handout section of the pane on the right, and I believe they also go out with the recording link.
Excellent.
We already have some comments on what an excellent presentation that was. I will echo that. Thank you so much, Dr. Allen, for your participation and for sharing such a great presentation. Everybody, when you leave today's webinar, you will receive an email with a short survey. We appreciate it if you complete that and submit your feedback. You will also receive a follow-up email again within 2 hours to view a link to the recording of today's webinar. On behalf of the American Heart Association and Dr. Allen, thank you for joining us today. Have a great rest of your day and happy Heart Failure Awareness Week.
Thank you.
Thank you.